At this point, we've learned about why the conversation of AFib is so important. Now let's dive a little deeper. Dr. P, can you explain the differences between normal rhythm and atrial fibrillation?
Thank you for the question, Lindsay. That's a great question. Unlike normal rhythm that's well organized, atrial fibrillation is a grossly irregular one and often very rapid in the top chambers of the heart. The atrial rates typically exceed 400 beats a minute, but much fewer of the beats from the top chambers get to the bottom of the heart through the conducting system. Because these beats get to the bottom of the heart in a very random way, the typical pulse that one takes is irregular, and it could be slow or fast depending on how many of the beats from the top chamber get to the bottom of the heart. Note in the figure of the house, atrial fibrillation is depicted in the upstairs of the house as many people bumping into each other and are trying to get down to the bottom over the staircase, but only a few of them can actually get there. Comparing this to the picture of the heart, you can see what is depicted as multiple electrical impulses in the top chamber, and they're trying to get to the bottom of the heart. The corresponding 12-lead electrocardiogram shows none of those regularly spaced P waves we've seen in normal rhythm, but now you see a wiggly baseline, and that's from the rapid impulses of the top chamber, and then you get an irregular R wave that represents those beats that finally do get to the bottom of the heart. This is also depicted on a rhythm strip where the heart rate is now faster because many more of those upper chamber impulses make it to the bottom, and therefore the heart rate's faster.
Can you show us an example of what this looks like in a patient?
Sure, be glad to do that. This was a patient who was undergoing a catheter ablation procedure to try and cure atrial fibrillation in our electrophysiology laboratory. In these situations, we place several catheters inside the heart, especially in the top chamber of the heart. You can see that the normal sinus rhythm on the left-hand side of this figure shows no abnormal electrical activity in the heart. But one of the catheters is actually placed in one of the pulmonary veins, and toward the right side of the heart, you can see it suddenly shows very, very rapid electrical impulses coming from that vein. These impulses now leave the vein, they enter the left atrium, and once that happens, the entire top of the heart goes into atrial fibrillation. We'll discuss the actual ablation procedure to cure this at a later part in this series.
Could you even go deeper than that and show us what happens in AFib using an animation?
Sure. This is an animation showing the difference between the sinus rhythm animation we saw in Chapter 1 versus now in atrial fibrillation. Remember, the major differences are going to be that the top chamber now is in a very rapid rhythm that creates disorganization as far as electrical activity goes, and therefore these impulses go down the conduction system, and they go down in an irregular manner and reach the bottom of the heart in a regular manner. So as you can see from this animation, the top chambers are now like a wiggly kind of a structure, almost been described in the past as a bag of worms, just wiggly along them. There's no defined muscle organized contractility, and therefore the impulses get down irregularly, and the corresponding electrocardiogram is also irregular.
That visual is really helpful. Dr. P, are there different categories of AFib?
Lindsay, there are. So there are basically 4 categories, and we use this in our discussions with patients to give them a handle on what it means to be in different types and what treatment options are. The first type is called paroxysmal AFib, and this represents AFib that comes and goes, but it always stops on its own. Now, the durations of episodes can be very short in seconds, or they can even last several days, but they do stop on their own. Persistent AFib means that it doesn't stop on its own, and it requires either medications like drugs or electrical energy applied across the chest wall, called a cardioversion, to restore normal rhythm. Then, as electrophysiologists, we've added a couple other categories that are important to us because we know how they will affect the long-term issues with patients. One of them is called long-standing AFib, and it's just a name we've given to persistent AFib that's been there for at least a year. And we'll go later on and describe why that becomes an important category. Last of all, there's a category called permanent AFib. What that really means is that the patient is either not able to get back into normal rhythm, or in a discussion with the patient and the physician, it's not considered important and they just spend the rest of their time in atrial fib.
What about symptoms? What should we be watching for?
Well, this is a very difficult thing for patients because they have in their minds many times they're supposed to have a certain kind of symptom. But let me show you from this table that symptoms are quite diverse and often not there. And one of the most common ones is palpitations. Now, one of the things I learned years ago when I would ask patients when they come into the office, tell us what your symptoms are, and there's a section that says palpitations. And I'd have these patients coming in feeling that they've really been out of rhythm, but they never checked palpitations. And it took me a long time, unfortunately, to realize patients don't necessarily call what I call palpitations, palpitations. And they'll often describe a fluttering in the chest, sometimes like fish flip-flopping around. And you have to kind of dig a little bit to see that symptom. Shortness of breath, lightheadedness, fatigue, and no energy are very, very common symptoms of atrial fib. Some patients really just have a sense of not feeling right, cloudy thinking. They just know something is not there. And less commonly in my experience are things such like chest pain or even loss of consciousness. Importantly, and this is really important, many patients actually don't know they even have AFib. And this can be true even when the heart rate is considerably fast, over 100 beats a minute. I'm often referred patients with newly diagnosed AFib at their yearly office visit with their primary care doctor, and sometimes they'll be picked up on things like procedures like a colonoscopy. But we should say that the fact that you're not feeling AFib does not take away from some of the risks of AFib.
And I would imagine that that's why simply having this conversation could be life-saving.
It could.
And we'll move into exploring what diagnosis looks like next.